السلام عليكم ورحمة الله. I am Dr. Rahman Mokhtar, Professor in Internal Medicine, subspecialty in hepatogastroenterology. I will spend the coming hour with you about this subject. This is the first topic in hepatogastroenterology. As you see, the title, Interpretation of Liver Function Tests. I think this is a very important lecture for all of you, whatever your career in the future. Because whatever your specialty, I think every day you will see a report of liver function test. Not only for internists. If you are a surgeon, a gynecologist, you will have a patient with a report of his liver function test. So it is very important to be clever, to know the art, how to read this liver function test in the proper way. So I hope this lecture will be clear. If you feel any point missed from you, you have the right to interrupt me to clarify the point, and let's start. As you see from the title, Interpretation of Liver Function Tests, before starting, we should know or remind ourselves what are the liver functions. From your study in biochemistry and the previous years, what are the liver functions? Can anybody remind me? Detoxification. What else? Metabolic functions. As you can see, healthy liver has a lot of functions. Purification, transformation, the clearance of toxins, drugs, hormones, etc. Storage of glucose and other nutrients, regulation of lipid and glucose metabolism, synthesis and secretion of clotting factors, and so on and so. Almost around 500 functions the liver is doing. So, the liver does too much for any single test or set of tests to determine. That's why we are not using one test. We are using the term liver function test. By liver function test, we mean these are groups of laboratory blood assays designed to give information about the state of the patient's liver. The parameters measured include prothrombin time, INR. You know what is INR? This is another expression, a way to express the prothrombin time. As you may know, the prothrombin time level, there is a great variability between labs. So, INR means International Normalization Ratio. To speak the same language all over the world, whatever the control, whatever the liver, you will transform into INR. So, prothrombin time, INR, albumin, bilirubin, direct and indirect, and liver enzymes, SGPT, SGOT, alkaline phosphatase, and gamma-glutamine transferase. As you see, some tests are associated with functionality, like prothrombin, albumin, and bilirubin. Prothrombin production is one of the original liver functions. Albumin synthesis is another one of the basic liver functions. Bilirubin excretion is one of the excretory liver functions. So these three tests are really representing functionality. However, some other tests, although included here, they are concerned with cellular integrity, like transaminases. Transaminase production is not a real liver function. Transaminases are intracellular enzymes. When the liver cell is injured or damaged, they are released into the circulation, so increase in disease. So they represent cellular integrity. And some other tests are linked to the biliary tract, like gamma-glutamine transferase and alkaline phosphatase. So, although the liver function test seems to be a misleading term, because it is all these tests are not real functions, yet it is firmly inserted in the medical vocabulary. It is a very old term that has been established in the medical literature and the medical texts that it is accepted term, but we should be minded that this term is not only functionality but include all these tests. What are the indications to do liver function tests? These tests can be used to detect presence of liver disease, of course, distinguish among different types of liver disorders, gauge the extent of non-liver damage, and follow the response to treatment. Some or all of these measurements are also carried out on those individuals taking certain medications to ensure these medications are not harming liver. On regular periods, Q3 months, Q6 months, according to the type of medication, like anticonvulsants. So these are the indications. And now, what are our tools? We are professionals. Anyone in any profession should have his tools and should know his tools. You should know the abilities of these tools and also the limitations of these tools. So let me introduce you these tools that we will use to assess the liver function. Our tools are transaminases, SGPT and GOT, gamma-glutamine transferase and alkaline phosphatase, prothrombin, thyme, albumin, and bilirubin. We will take 2 minutes to introduce these tools. As you may know, these are the group, alanine aminotransferase. It indicates hepatocellular damage. Aspartate aminotransferase also, the same in significance. Bilirubin, increase in cholestasis, impaired conjugation or biliary obstruction. Alkaline phosphatase, increase in cholestasis, infiltrative disease. Prothrombin, thyme, and albumin, the real synthetic function, representatives of synthetic function of the liver. Gamma-glutamine transferase, increase also in cholestasis or biliary obstruction. Bile acids, 5-nucleotidase, like alkaline phosphatase, cholestasis or biliary obstruction. Lactate dehydrogenase also indicate hepatocellular damage, but not specific to the liver. We will have 1 minute for the commonest 2 enzymes well known to be done for hepatic patients, the AST and ALT. Aspartate aminotransferase, AST, it can originate from the liver, heart, skeletal muscles, kidneys, brain, RBCs, so it is not specific to the liver. In the liver, 20% of AST activity is cytosolic, and 80% mitochondrial. Why I mention this? This is very important, because few minutes later you will know that a disease like alcoholic liver disease, which mainly affect the mitochondria, will cause marked increase in AST rather than ALT. That's because the alcohol is damaging the mitochondria, and AST is mainly mitochondria, while ALT is totally cytosolic, more specific to liver, a very low concentration in kidney and skeletal muscles, and liver totally cytosolic. These liver enzymes are important markers of liver injury, but are not real liver function, and are not accurate markers of severity of liver disease, as we will see. Month-to-month variations is expected. Minor changes in levels have no prognostic significance. This is very important because you will face the patients so anxious about their enzymes. The patient came this month, oh doctor, my GPT, GOT is 45 last month, and this month it is 52. It increased, and he's so anxious. You should assure him that these minor variations has no prognostic values. Okay? The other enzyme is alkaline phosphatase, which is present in nearly all tissues, but with different isoenzymes. There is isoenzyme in the liver and isoenzyme in the bone and so on. In the liver, it is localized in the microvilli of the bile canaliculus, also present in bone, intestine, placenta, kidney, and white blood cells. Elevation may be physiological or pathological. 5-nucleotidase is always the friend of alkaline phosphatase. It has the same significance. It is more specific to hepatobiliary disease, so may be used to confirm hepatic origin of elevated serum alkaline phosphatase. As you see, alkaline phosphatase has several sources. So if alkaline phosphatase is increased, and this increase is associated with increase in fibrous nucleotidase, this indicates hepatic origin. But if isolated increase with normal fibrous, mostly look for other sources. Now, as I mentioned before, we should know and be oriented about the limitations of these tools to be able to optimize their use. This liver function test lacks sensitivity, may be normal in cirrhosis or hepatocellular carcinoma, and lacks specificity. Aminotransferase, for example, may be elevated in musculoskeletal or cardiac disease. GOD is increased in acute myocardial infarction, so they are not specific to the liver. Degree of elevation does not always correlate with severity of liver disease. As you mentioned, it may be normal in cirrhosis, because in cirrhosis, this is an end stage of liver disease. Almost no more liver cells to be injured to release enzymes, so enzymes will come down. This does not mislead me that everything is okay. No. Degree of elevation does not always correlate with the severity of liver disease. So a group of tests is needed in order to infer functional liver status. Probability of liver disease is high when more than one test is altered, and or the findings are persistently abnormal, not one reading. For borderline readings, try to repeat and to look. If more than one test are affected and more than one occasion it is persistently elevated, this tends toward a real liver disease. Mixed injury obstruction patterns are common in real life. We will come to this later on. Anormal does not mean normal. This is very important, not to mislead you. Do not assume that a normal test result indicates absence of liver disease. As we mentioned, there is a lot of confusion. So, considering these limitations while you are assessing the liver function is very important to avoid pitfalls. What is this? Can you tell me? A face. Anyone? Another answer? What? A bridge. One of your colleagues said, this is a bridge. Yes, this is a view from Paris. This is a bridge, and this nose actually is a person with umbrella under rain. So this is the message. You should have the deep look, the wise look. This is our lecture today. So it is not simple reading of liver function, but I need you to interpret, to have a deep look. So, to our lecture. This was the introduction. I'm sorry for this. Okay? I hope during the coming minutes to get the basis to have this deep look, to know where are you, to assess the liver function in the proper way. Let us go. As we mentioned before, there are general categories of liver function tests. There are tests of biosynthetic capacity of the liver, like albumin and the prothrombin. Tests to detect injury to hepatocytes, like GPT, GOT, LDH. When hepatocytes are damaged, they leak and increase in the serum. Markers of cholestasis and obstruction, like alkaline phosphatase, gamma glutamate transferase, and bilirubin. And lastly, type 4 collagen, fibro tests, etc. Tests to detect fibrosis in the liver. Actually, this last group is relatively recent in the field of medicine. You know that the gold standard to detect fibrosis still up till now is liver biopsy. But liver biopsy as an invasive procedure, which is tedious and not always welcomed by the patient, push us to try to look for non-invasive way to assess fibrosis. This now, in the last few years, start to come these non-invasive tests, like type 4 collagen and fibro tests, but actually, historically, these are the most recent member of the group of liver function tests. But you will not see as a routine. unless you are internist or working in the field of hepatology, you will not see it frequently. You will see the other historical group. Okay? And now to the roadmap for proper interpretation of liver function tests. We will put 6 steps to be able to give a real judge for the liver function. Step 1, think of non-hepatic causes. When you have a look to liver function, before rushing to put hepatic diagnosis, don't forget, think of non-hepatic causes. Second step, look at pattern of abnormality. Cholestatic versus hepatocellular. Step 3, look at tests of renal function that we mentioned before. After you finish the first column, you can, on the basis of the first three steps, you can classify the abnormality, whether you are dealing with hepatocellular or biliary disorder. Is there massive hepatocellular injury? Evidence of functional abnormality is there or not? At this stage, you can start to consider a differential diagnosis, considering the most common and the most treatable. And then you can perform your diagnosis, depending upon, this is very important, history, examination, and investigation. So, the final diagnosis, you will read these liver function tests, considering the history of this patient and the clinical signs you will find during the examination. So the final decision is not a lab. Your liver function tests will be read through all the scheme, through all the view, the history, exam, and then comes the liver function test. This is the core of our lecture today. I hope these 6 steps to be clear for everyone. Okay? So let us start to see how we will do these 6 steps. Step 1. Think of non-hepatic causes. As I mentioned before, these enzymes are not specific to the liver. Examples, bilirubin elevation, the source may be RBCs, like hemolysis, hemolytic anemia, intra-abdominal bleeds. If there's intra-abdominal bleeding and the blood will disintegrate and release bilirubin, it will increase, or hematomas. AST, the source may be skeletal or cardiac. As I mentioned before, acute myocardial infarction may cause increase in AST. Alkaline phosphatase, the source may be bone, placenta, kidney, or intestines. You should be aware not to see a pregnant lady and found alkaline phosphatase is high and start to rush to investigate for dilatation. This can be exciting. Gamma glutamine transferase, the same story. Now, step 2. Look at pattern of abnormality. What is the main change? Usually, in real life, you will find a change in more than one test. But the major change will direct you to the pattern or the type of the disease. Either the problem is hepatic, in the liver cells, hepatic, you will increase. With marked injury in liver cells, you will find increase in ALT and increase in AST. ALT, as we mentioned, is more specific to the liver. So don't forget, L is specific for liver. AST, S means other sources. ALT is more specific, AST can be from other sources. So if you found the main increase in ALT and AST, we are dealing with a disease that influences mainly hepatic cells, or the other pattern, cholestatic pattern. There is marked increase in alkaline phosphatase and gamma GT. This means that we are dealing with a cholestatic disorder. This is the 2 main categories. But even within the same category, like the hepatic, if we have a deep look to the pattern of increase, there are certain patterns that can help us. What is the ratio between AST and ALT increase? If the AST is markedly increased rather than ALT, usually 2 to 1 or 3 to 1, this usually happens in alcoholic liver disease. As I mentioned before, ALT is more than AST, can happen in NAFLD or NASH, non-alcoholic fatty liver disease, or non-alcoholic steatohepatitis. If the magnitude ALT more than AST and it reaches to thousands, 1,000-fold the normal, usually you are dealing with acute viral hepatitis, acute ischemia, or toxins. Why the AST is more increased in alcoholic? As I mentioned before, that alcohol causes mitochondrial damage, releasing more AST. Another factor that alcoholic patients have, usually they have vitamin B6 deficiency. The decrease in ALT is more strongly inhibited by vitamin B6 deficiency, which is common in alcoholics. So these two factors can explain why in alcoholics the AST is markedly increased. Now to the third step, look at the tests of functions. What are tests of functions? Can you remind me? Huh? Tests of function. What? Which test? Yes. Prothrombin and albumin. Yes. This is albumin and prothrombin time, or it's as expressed as INR. Regarding the albumin, it depends on nutrition, hormonal factors, catabolism, loss in stool and urine, not specific for liver disease. For all these reasons, albumin is not that specific to liver disease. There are a lot of playing factors. So, measurement of serum albumin is useful in chronic liver disease and is a component of grading systems. We have grading systems to grade the severity of the liver disease. We will mention later on. Serum albumin is one of the parameters of this grading system. Obviously, non-hepatic causes of hypoalbuminemia need to be excluded, like proteinuria and malnutrition. For example, I have a diabetic patient and he has chronic HCV. I found albumin is low. How many possibilities we have here? Huh? We have two possibilities. Either this low albumin is really denoting advanced liver disease and there is decreased albumin synthesis, or the other possibility that this diabetic patient has diabetic nephropathy and he is losing his albumin in urine. Am I right? How you will differentiate? Try to think. Yes, you can check the kidney. How you will check the kidney? Albumin in urine. Urine sample and check if there is albumin loss in urine or not. This is one differentiating point. The other, I look to the other synthetic function of the liver, which is the prothrombin. If the prothrombin is normal, completely normal, and the albumin is low, mostly this low albumin is from other causes. Okay? So we should consider all these points. The albumin has a long half-life, from 20 to 30 days, and is not therefore a good indicator of liver dysfunction in acute hepatic injury. So the value of albumin in chronic liver disease rather than acute. And now to the other synthetic function, which is the prothrombin time, or INR. In presence of adequate vitamin K, the liver synthesizes coagulation factors except factor 8. Clotting abnormality indicates impairment in ability of liver to synthesize clotting factors, provided there is adequate vitamin K. So this means that you have excluded vitamin K deficiency. In vitamin K deficiency, vitamin K 10 mg sub-Q decreases prolonged prothrombin time more than 30% within 24 hours. What this means? If I have a hepatic patient and the prothrombin time is prolonged, this could could be due to vitamin K deficiency, or there is enough vitamin K, but the liver cell cannot synthesize. So to differentiate, if you give this patient 10 milligram vitamin K sub-Q and repeat the prothrombin time, it's supposed to decrease by 30% within 24 hours. If prothrombin time decrease, so this is a case of vitamin K deficiency. When I give vitamin K, it's correct. But if I give and no change, this means that the liver cell cannot synthesize the vitamin K. This is the answer. So, prothrombin time is a useful indicator of liver failure in both acute and chronic. We mentioned that albumin I cannot use in the acute because it has prolonged half-life. So the change in the acute condition will not be clear. But for prothrombin, it is useful indicator of liver failure in both acute and chronic hepatic injury, provided the cholestasis with malabsorption of vitamin K has been excluded by parenteral administration that we have mentioned already. So, in acute liver failure, the prothrombin time may rise to over 50 seconds, and is the most important predictor of outcome. And it is one of the most important figures considered for urgent liver transplant. The centers of liver transplant put their criteria for urgency of liver transplant. One of the very important indicators is prothrombin time. Okay? How about in cirrhosis? In cirrhosis, livers are usually 2 to 5 seconds prolonged. A prothrombin time elevated to over 20 seconds in a cirrhotic is an indication of very poor synthetic function and is associated with a poor outcome. So prothrombin time is a very good indicator in both acute and chronic liver disease. This is the grading system I mentioned before. One example is a modified child-body score for grading of severity of liver disease. You can see the parameters considered to assess the severity. The serum bilirubin, if less than 2, or from 2 to 3, or more than 3. Serum albumin, more than 3.5, 2.8 to 3.5. Prothrombin time and INR, then 2 clinical parameters, ascites and encephalopathy. So, this system reminds you that only the real function tests who are represented in the grading, who represent the prognosis of the liver disease and the severity of liver disease. Rather than you will not see GOT or GPT in this grading system. Okay? Now to step 4. To classify the abnormality. On the basis of the previous steps, now we can classify the abnormality. We are dealing with hepatocellular or biliary problem. Is there massive hepatocellular injury? Is there evidence of function abnormality? Classifying the abnormality. Primarily, hepatocellular or biliary injury. Hepatocellular, you will find the main change in AST and ALT versus the main change in alkaline phosphatase, gamma GT or bilirubin. This toward biliary injury. Is there massive hepatocellular injury? If AST and ALT suddenly rise more than thousands, mostly there is massive hepatocellular injury. Is there evidence of functional abnormality through prothrombin time, INR, albumin, and bilirubin? The first step to consider the differential diagnosis. Now, we can reach to which category of disease we are dealing with. Cholestatic, hepatic, there is massive injury, no massive injury, there is functional affection, no functional affection. Now to consider the differential diagnosis, the most common and most treated. Actually, I would like to give you a hint here. I'll give a lot of examples. Don't be frightened, please. Because I want to give you the outline of thinking rather than to fill all these examples. I'm sure if you get this roadmap and start to apply by the end of the year, you can fill in the space by yourself. No need to remember all these lists. These are examples, but along the coming year, My colleagues will give you every day a new liver disease. By the end of the year, you can fill in the space. Examples for cholestatic liver disease, 1, 2, 3, 4. Example for hepatitic, 1, 2, 3, 4. So don't be worried about becoming less, please. Okay? Now we will have the differential diagnosis of hepatocellular damage and the differential diagnosis of cholestatic pattern. For hepatocellular damage, this is a long list of diseases that can cause hepatocellular damage. This is given empirically in alphabetical to be easy to remember. Autoimmune hepatitis, hepatitis B, C hepatitis. As I mentioned, this is put on alphabetical, but we should consider what is common. If we are here in Egypt, endemic area, in HCV and HPV, HCV should be on the top of the list. I will never put autoimmune as a first possibility, unless there are other clues. But this is just simple alphabetical arrangement to be able to remember. Not only the causes, the pattern of change in liver enzymes can help you to categorize the diseases or to narrow the differential diagnosis. For example, in ischemic injury, you will find marked increase in enzymes, more than 10 folds up to 50 folds, more than 50 folds. You will find 10,000 AC and ALT, okay? And the amyloid-transferase levels rapidly decrease after initial peak. It will go up, shooting up to 10,000 and rapidly decreasing. And usually there is a comorbid condition. You will find a cause for this ischemic injury happen, for example, a patient with acute myocardial infarction, and he passed into cardiogenic shock for half an hour or 1 hour and then resuscitated. During this half an hour, with drop of hepatic perfusion, ischemic injury happened. The liver enzymes should, then after resuscitation, it rapidly comes down. So this pattern suggests ischemic injury. Toxic injury, like paracetamol, hepatic toxicity, which is the most common example, will give you a rise almost more than 10 folds also. And you will find the history suggestive of toxic injury. He will give you history that he took this medication. In acute viral hepatitis, the rise is somewhat from 5 to 10 or more than 10 folds. But in acute viral hepatitis, the recovery will be slow. It will not be like ischemic injury. Slow decrease of amyloid-transferase levels and the risk factors. Is it clear? Okay. Acute biliary obstruction, usually you will find amyloid-transferase level not that high. You will find the main increase in the bilirubin and cholestatic pattern. Alcoholic hepatitis, the increase from 5 to 10, and the AST will be more than ALT. So understanding the pattern and reading the pattern as a whole is very essential. To narrow the differential diagnosis, again the same idea. This is a differential diagnosis for mild elevation in the enzymes. By mild we mean less than 5 times the normal. This is a long list. Hepatic causes, ALT predominant, chronic hepatitis C, chronic hepatitis B, acute viral hepatitis, steatosis, and so on. Or non-hepatic causes, hemolysis, myopathy, thyroid disease, and so on. On the contrary, on the other side, differential diagnosis of severe elevation of ALT. If we find severe elevation, which means more than 15-fold the upper level of normal, this will narrow your differential diagnosis. Usually, indicate marked hepatocellular injury or necrosis due to drug-induced acetaminophen or environmental toxin or ischemic hepatitis or acute viral hepatitis. So if I found marked increase, it will limit your differential diagnosis. Mild increase, this is the differential diagnosis. Moderate increase, usually elevation in the intermediate range is less useful for limiting the differential diagnosis because causes from both sides can present with moderate increase. And now to the differential diagnosis of cholestatic pattern. We will give the differential diagnosis of markers of cholestasis. As you can see, what are the markers of cholestasis? Number one, alkaline phosphatase. The last one is bilirubin. This is very important message because in our brain the cholestasis means bilirubin high. I want to change this today because bilirubin can increase in hepatic injury. So it is not the first marker of cholestasis. The first marker of cholestasis is alkaline phosphatase. If you found bilirubin high with normal alkaline phosphatase, this usually means hepatic synthetic dysfunction. So don't forget that cholestasis, number one, alkaline phosphatase. Alkaline phosphatase increase. It may be isolated increase, may be associated with hyperbilirubinemia, may be the sole abnormality in many cholestatic or infiltrative disease, the only abnormality. In primary biliary cirrhosis, it may increase years before the bilirubin. To be interpreted in the clinical setting of history and physical examination, if the sole abnormality. Gamma glutamate transferase, it has the same significance. Usually, as I mentioned before, it confirms the hepatic origin of the alkaline phosphatase and then the bilirubin. Alkaline phosphatase can increase in certain physiological situations, don't forget them, in tissues undergoing metabolic stimulation, in third trimester of pregnancy. It can originate from the placenta. So if a pregnant lady and I found high alkaline phosphatase, this is physiologic increase. And in adolescents with their growing tissues. Causes of elevated serum alkaline phosphatase, either hepatobiliary or non-hepatic. Hepatobiliary, bile duct obstruction, primary biliary cirrhosis, primary sclerosing cholangitis. As I tell you, don't be frightened from these tests. By the end of the year, I'm sure you will give more long lists than me. So this is only examples. Don't be frightened. I need you to concentrate on the outline. The examples, by the end of the year, you can give me a lot of examples. Okay? Hepatobiliary or non-hepatic. Don't forget that infiltrating disease of the liver can cause also elevation of the serum alkaline phosphatase, like sarcoidosis, TB, fungal infection, amyloidosis, lymphoma, and so on. When serum alkaline phosphatase elevation is detected, you should repeat the test to be sure. As I said, persistent change suggests that there is a liver disease you need to investigate. So you should repeat the test. Number two, to confirm the hepatic origin by gamma glutamate transferase or 5-nucleotidase or the alkaline phosphatase isoenzyme. If medication is suspected, discontinue them and repeat the test. If the patient gives history of medication and there is a possibility that this drug has induced the high alkaline phosphatase, you can stop the medication and later on repeat the test. With this, if you took these steps and still there is persistently elevated serum alkaline phosphatase, you should evaluate for cholestatic liver disease, infiltrative liver disease, or biliary obstruction. Usually you should also consider the level of increase, as we did with hepatocellular. Alkaline phosphatase elevation up to 3 times the upper limit of normal is non-specific, can occur in all types of liver disorder. You may find slight increase but not exceeding 3/4 of the upper limit of normal. If more than 3 times the upper limit of normal, you should think for cholestatic disorder, infiltrative disorder, metastasis, or biliary obstruction. So this is the algorithm for raised alkaline phosphatase. If you found high alkaline phosphatase, check for gamma GT. Check for gamma GT. If no increase, this is non-hepatic cause. Go away for search for the cause in other direction. If there is increase, so this is mostly hepatic. If the alkaline phosphatase is twice to triple the normal, ultrasound, or if the patient is symptomatic, ultrasound, or persistent increase more than 3 months, whatever the level of increase, do abdominal ultrasound. Abdominal ultrasound, you will look for, is there any liver masses, infiltrating mass? Yes, further investigation for a liver mass. Or there is bile duct dilatation, which means biliary obstruction. you will go for ERCP. You know ERCP, endoscopic retrograde cholangiopancreatography, some sort of endoscopy for the biliary tree. If no bile dilatation and no liver mass, you will think for medical cholestasis. Check for anti-mitochondrial antibody for the primary biliary cirrhosis, and consider liver biopsy or MRCP depending on other finding and ultrasound. MRCP is magnetic resonant RCP to check the biliary tree through the magnetic resonance. So this is the general approach. Okay, for high alkaline phosphatase. Exclude non-hepatic cause, then if persistent, do ultrasound and go ahead according to the algorithm. For gamma GT, as I mentioned before, the main use is to confirm the hepatic origin of serum alkaline phosphatase. And now to the last marker of cholestasis, which is the bilirubin. I think all of you from biochemistry and physiology know this circle of bilirubin. Bilirubin originates from the senescent red blood cells through the reticuloendothelial system. It will produce bilirubin. Free bilirubin will be taken up by the liver. The liver cell will do 3 steps with the bilirubin. Uptake of the free bilirubin, conjugation to convert this free indirect bilirubin into water-soluble conjugated bilirubin, then excretion through bile. Hyperbilirubinemia can happen either through excess production, this is non-hepatic cause, hemolytic disorders and so on, or 3 steps from the liver, either defective uptake, or defective conjugation, or defective excretion. And as you see, if the cause is pre-hepatic, excessive production, or defective uptake, the increase will be mainly in unconjugated bilirubin. If there is hepatic or genetic defect or primary liver disease, it will influence both the uptake and the conjugation. It will be mixed. If post-hepatic, a problem in excretion, biliary obstruction, the main increase will be conjugated bilirubin. And I think the coming lecture next week, inshallah, or this week, will be Dr. Abdel will talk to you about jaundice as a whole. But this is the general outline. So, considering the differential diagnosis, this is the 2 slides before. This is the differential diagnosis of both predominantly hepatocellular pattern, predominantly cholestatic pattern, or isolated hyperbilirubinemia. And as I mentioned to you, don't worry, by the end of the year, you will put this list spontaneously. Don't forget this. I was intended to put this slide to remind you that drugs can influence the liver function in any of the 2 ways. It may cause cholestatic pattern, and other drugs can cause cytotoxic or hepatocellular pattern. This is a long list of drugs which can cause cholestasis: amoxicillin, carbonic acid, anabolic steroid, chlorambucil, and so on. And this is a long list of drugs that can cause hepatocellular pattern. So, I was intended to put this slide to remind you. Please give your patients 2 minutes to take a good history. If you do not take a drug history, mostly you will miss the diagnosis. So don't forget, it is not only to read liver function test, but to see the skin, what happened, how this changed. The history is very important because drugs is a very important item in the history. Now to the last step, which is step 6. To perform diagnosis. As I mentioned, history, examination, and investigation. To give your final decision about this liver function. History, whether the patient is asymptomatic or symptomatic. Asymptomatic patients, you know, a lot of patients, they don't have any symptom, but just during routine checkup, they tell him you have some change in your liver function test. He comes frightened, doctor, I have some problem in the liver. This is my liver function test. Do you have any complaint? No complaint. Just a lab finding, how it will be. Or he has certain symptoms. By examination, combined with the history, you can differentiate. Is this hepatocellular versus cholestatic, compensated versus decompensated? There are further investigations. You will order to complete your diagnosis. These are not from liver function tests, but according to the situation. Let us see how. For asymptomatic patient, in asymptomatic non-jaundice patient with abnormal liver function test, it is worth initially to exclude an alcohol etiology and reducing alcohol intake, maybe alcohol. Or at the same time, he may be taking any herbal medicine, any drugs. You should ask. Stopping drugs started within the last 3 months, excluding drug toxicity from non-prescribed herbal remedies, then repeating liver function in 2 to 3 weeks. If liver function tests remain abnormal, an appropriate chronic liver disease screen and an abdominal ultrasound scan should be undertaken. This is for the asymptomatic. Okay? During the history, you should consider risk factors for liver disease. A long list of risk factors, like high-risk behavior for IV drug users, multiple sexual partners, high-risk sexual activity, tattoos, and so on. All these practices expose him for parentally transmitted hepatic viruses, B and C. Commonly implicated medications, again, the history of drug, the history of drug, the history of drug. Acetaminophen, antibiotics, and so on. Systemic illnesses. One of the commonest causes of altered liver enzymes is non-alcoholic fatty liver disease, which is common in metabolic syndrome. Now, non-alcoholic fatty liver disease is the hepatic manifestation of metabolic syndrome. So, how you will find metabolic syndrome among diabetics, obese, hyperlipidemia, and overload, and so on. Other risk factors like needle stick injury, a nurse which has been exposed to stick or a medical practitioner, patient on hemodialysis, exposed to machines and drugs. All these risk factors should be in mind during history taking. For examination, you can judge, is the patient giving manifestation suggesting cholestatic disease or hepatocellular disease? For example, manifestation of cirrhosis and portal hypertension, flapping tremors, spider nevi, fetal hepaticus, John, and so on. Or there are manifestations suggesting accumulation of bile constituents, like jaundice, bile acids, pruritus, itching marks, xanthelasma, cover will cause cancer pressure ring. All these increase suggest cholestasis. At the same time, reduced bile in intestine in all cholestatic disorder will cause malabsorption of the fat-soluble vitamins, like vitamin A, D will present by osteomalacia, vitamin E, vitamin K, and fat steatoria, and so on. So the history and examination is very important to direct you for the proper reading of the liver function. And the last step, further testing as needed, according to the situation. For example, if a patient with elevated enzymes, history, and physical exam, you confirm the elevation by retest. You found in the second time the test is normal. Test for hepatitis C antibody because you are in endemic area. If positive, hepatitis C RNA, and go ahead according to the result. If the test is abnormal, you should revise your history and examination. If an obese and diabetic patient, you should think for non-alcoholic fatty liver disease. If the patient has other autoimmune disease, has vitiligo, has hypothyroidism, has another member in the family with autoimmune disease, screen for autoimmune hepatitis. You can ask for anti-nuclear antibody, anti-smooth antibody, and so on. If you found that the patient, young patient with associated neurological manifestation or family history of Wilson disease, think for Wilson. Send to check to ophthalmologist if there is Kaiser vision or no. You can ask for cerebroplasmy, 24 hours urinary cover, and so on. If the patient has bronchial diabetes, dark colored skin, think for hemochromatosis, ask for ferritin and saturation gene for hereditary hemochromatosis, and so on. If the patient has history suggestive of high risk or endemic area, viral hepatitis, alcohol, and so on. So these tests are not a routine. These are suggested by the skin and by the situation. So, by the end, can you read this? What is it? Me. Any other answer? You. Is it me or you? Or both? So the message is, interpretation of liver function tests is more than simple reading. You should have deep and wide. This is the background, and it is me, actually. Okay? Thanks a lot. Any question? Any question? What happened? هيبقى available هينزل على الموقع بتاع الاسم.